I'll say I kind of. I research my things. That's when I have to.
I'm glad you're doing this, you know, but...
So NAS was a topic that when I put it out to the community, what they would like to learn about this year was an overwhelmingly large response. And thankfully for us in our own NICU, we have Valarie, who's finishing her doctoral work with this being her area of focus. And so I thought that we probably wouldn't have a better person in our community to come and educate us on kind of what the latest, newest, et cetera, is on NAS. So I'm going to hand it over to Valarie, and we'll get started.
Thank you. Good morning, everybody. Some of you I know because I've been the lead NNP here for 20 years with Dr. Kovacs. Some of you I do not know. So I am the coordinator for our allied health professionals in our neonatology division, and I am also the coordinator of our well newborn services out at our sister hospital, Northern Dutchess, in their birthing centers. So today we're going to talk about how our pediatricians can manage NAS in the well newborn nursery. And some of the objectives I will go over. This presentation I also used with the nurses to a certain extent when they were being instructed and educated on using the short form for our FINNEGAN tool that we also use in the well newborn nursery. And some of the slides are geared more towards the medical provider actually in the well newborn nursery. But some of the objectives that we'll look at is we're going to define addiction. We're going to define what neonatal abstinence syndrome actually means. We're going to look at the FINNEGAN scoring system, which is the classic tool that is being used in scoring our babies that are exposed to drugs in their in utero production. And we're also going to look at the short form, which we are using with some regularity now in our newborn nursery and with quite a bit of success, and we'll talk about that a little bit more. And then we're also going to talk about the non-pharmacologic management strategies that you as the medical professional and the nursing staff in coordination can educate the parents and caregivers on in managing these babies, because as we know, they are difficult to manage. They are not normal newborns, and they tend to stay longer than a normal newborn will stay. And we'll talk about the clinical report that the AAP put out in 2012. They will have a new report coming out in 2016, but our working clinical report is the one that Dr. Hudak and Tan put out in 2012. And then we'll also talk about some strategies to support the mother and infant together as a couple. Definitely in part of nursing education and even in advanced practice, addiction was not something that we actually were taught about, and it is definitely something that we have to have an understanding of in order to actually work with these parents and really understand what's happening to these babies. It is a chronic disease of the brain. There are definitely dysfunction in the circuits that are characteristic to biological, psychological, social, and spiritual manifestations. There definitely is an inability to consistently abstain. There's impairment in behavior control, cravings, recognitions of the significant problems within one's behavior and interpersonal relationships. So even though these people who are addicted know that what they're doing is wrong, they cannot help themselves. It's almost, and I use this with the nurses, it's almost as if you are a diabetic and you just can't give up that sugar. You're going to take your insulin, you're going to work around it, but it can sometimes be that same thing. It's a craving that we have no matter what the addictive behavior is for. It also has cycles of relapse and remission. So why do we see our moms using drugs? Why do they use them? Why do they abuse them? Addiction does not discriminate. It reaches women of all colors, races, educational, and socioeconomic levels. Key factors and some of the things that they're looking at is genetic predisposal, but the more common ones that we see are the psychosocial, the environmental influences that may cause a woman to possess drug-seeking behaviors. So the addiction is a result of the prolonged use of prescription drugs or illegal drug use. Back in the 90s and the early 2000s, as providers, we always had to make sure our patients had zero pain. That was the push in the 90s and the early 2000s. Our patients should have zero pain. So Unfortunately, what we are now seeing is that we have some women who have become addicted to prescription medications because of medical problems they may have had in the past, whether it was a motor vehicle accident, whether it was a fracture of a bone and needed repair. So in our NICU, we see a cornucopia of why our mothers are addicted. It is not only from prescription drugs, but it is not also only from illegal drug use. Some of the women have turned to drugs because of a trauma that resulted in their life, whether it was emotional or physical. It could have happened as early as in their childhood, in their adolescence, or as an adult female in society. Some of the trauma that you will see will be that they were either raped, they were physically abused, they were mentally abused. So we have to have an understanding of what psychosocial events may have prompted this woman to seek out different drugs to help her basically kind of cloud what may or may not be going on in her life. Definitely there is a socioeconomic component to this: stress, poverty, the lack of social support, discrimination, and really just not having that loving family unit will also present with a woman who may have depression and low self-esteem, which is actually very characteristic with some of our moms that we do see in the nursery and in our NICU. They're not a trusting group of women because of the discrimination and the feelings that they feel that they're being judged. And so there's definitely some things that we can work on in order to make them comfortable during their stay and build that point of trust for them as in providing care. So when I first started looking at my research about 3 years ago, we had probably one baby every hour was born with NAS. We are now up to 2 babies. Dr. Patrick just released his latest findings from 2009 and 2012 in the New England Journal of Medicine earlier this year, and our numbers are astronomically rising, and it's throughout the United States. But we are not the only country that is actually seeing the increase of NAS. Australia has a high population of it. Canada has a high population. So it is something that is really worldwide. And why do we have it? And definitely here, even in New York State, we have very different regions. And like Dutchess County has a very high heroin. Crouse, upstate, they have a multitude of different illegal drug use up there where they're actually looking at different initiatives to how they're going to care for these babies. We aren't at that point yet, but that is one of my goals for next year, really to look at a quality improvement initiative and how and where do we care for these babies. So is it an epidemic? Absolutely. There are definitely states in the United States that have really looked at this in much more detail. New York State is a little behind, but as they gather their information from their ISTOP process that they now have put into place for drugs and prescription drug use, I think in the next 2 or 3 years we'll have a little bit more information on what our maternal addiction is. But states like Vermont, Tennessee, Ohio, and Florida, they have very intricate state regulations already in place. One state actually is incarcerating these women. They are the only state that is looking to do that. So the incidence and the trends, and this is the information that Dr. Patrick just put out in his latest article in the New England Journal was, so from 2009 to 2012, we went from a 3.4 to a 5.8 per 1,000 hospital births, these babies being born and diagnosed with neonatal abstinence syndrome. And the hospital charges have increased from $732 million to $105 billion in caring for these babies within this time frame. And approximately 80% of these costs are billed to the state Medicaid programs. Our length of stay for these NAS newborns in the NICU range between 13 and 19 days. Sometimes they're longer with us, depending on what pharmacologic agent we're using, in combination if they need a 2-drug to help with their withdrawal. But most of the time, even in the Well Newborn Nursery, when you have a normal 2 to 3 day stay, the clinical report from Dr. Hudak and Tan from the AAP suggests that anywhere between a 4 to 7 day stay is important for these babies to be observed in the hospital, and we'll talk about some of those reasons why we move along a little bit more. So in 2015, the Government Accountability Office released a report on prenatal drug use and newborn health, and what they felt were there were gaps in care and the federal efforts were not well coordinated in identifying moms with addiction and caring for these babies overall. So this is the new bill that is trying to be pushed in the legislature right now between the representative, Dr. Clark, she's from Massachusetts, and then Senator McConnell is from Kentucky. And they're really looking at this bill, and it's called Protecting Our Infants Act of 2015. This bill would direct the federal agencies to collect and disseminate strategies and best practices to prevent and treat maternal opioid use and misuse, and to provide the recommendations for identification and treating newborns with NAS. This would also direct the Agency for Healthcare Research and Quality to conduct a study and develop recommendations. The CDC would then be asked to provide the technical support for this data collection and surveillance activities for the newborns that are diagnosed with NAS. The bill would also direct the Department of Health and Human Services to develop the strategies to address research and program gaps for these women, manage them during pregnancy, and the aftercare of the NAS newborns and their neurodevelopmental long-term effects. So what is neonatal abstinence syndrome? It is a constellation of behaviors, both behavioral and physiologic, that are caused by the cessation of the exposure to licit and illicit drugs and substances during the pregnancy. NAS produces alterations in the functioning of the CNS, metabolic, vasomotor, respiratory, and gastrointestinal systems. So our frequency of NAS. So 50 to 80% of heroin-exposed infants will develop NAS. 60 to 90% of methadone-exposed infants develop NAS, and 60 to 80% of all infants with NAS will go on to require a pharmacological intervention. What we use here is oral morphine, and then if we need to add a second medication, it is phenobarb, and we only add the phenobarb if we cannot wean the baby successfully after 3 tries within a 7 to 10 day period. So what are the signs that you will see when you examine your baby in the nursery? They may have some. Most of them are not going to have all of these symptoms. But when we look at the neurological system, everybody knows that they have this very high, very piercing cry. You know it's not a normal cry of a newborn. They will have short and irregular sleep patterns. They will have tremors and irritability, and sometimes their tremors may occur when they're actually asleep or only when they're disturbed. They will have skin breakdown because they're constantly rubbing. Their faces will be chapped, their knees will be chafed because they're constantly rubbing because they cannot soothe and they cannot settle. They will have hypertonicity. If you're examining them and you're doing a hip exam, it's very tight to get these babies to relax. They don't want to relax against you trying to do your exam. They may have some mild clonic jerks at times. They will have frequent yawning and or sneezing, and the worst scenario that can happen with these babies is that they can have seizures, which is rarely seen but actually can happen. Their GI tract is the other system that is really very important to us, and especially when we're looking to score an infant, we're keen in not only on their neurologic issues, but also their GI symptoms. Their GI symptoms really tell us the degree of their withdrawal, and if they're going to be able to do it with a non-pharmacologic therapy, or if we're actually going to have to add a therapy to them. So they will have excessive sucking, they may not eat, they will act like they're hungry, but if the mommies are putting them to breast or bottle feeding, they're telling you that they just can't latch on to that nipple. They get very frustrated. But the vomiting and the loose stools are a very key component for us. These babies will vomit, they will have loose stools, and we'll talk about why we use the different formulas we use in the NICU with them, and they will not have very good weight gain. Sometimes these babies take 3 to 4 weeks to actually just regain birth weight, even with extra calories added into their diet, because their metabolic rates are so increased because of their withdrawal. In their autonomic systems, we'll see that they'll be sweating, so even though they may only be in a T-shirt and a blanket, when you go and pick them up, their blanket feels damp because they are sweating. Some of them will run a low-grade fever. They'll have 99 to 99.8. Nasal stuffiness sometimes can be seen. They can be tachypnic, And they usually have, when they have a severe case as well, you'll see them, they'll have modeling of a skin, as if you've taken the baby out of the bathtub and they catch a chill and they have this overall modeling of their skin. So the Finnegan scoring system is really the most widely used tool in the United States. I had the pleasure of working with Dr. Philip Lipsitz back in the late 1980s in his NICU down in Long Island, and he also developed a tool which is very similar now to the short form that is being used for Dr. Finnegan's tool right now. So our research, and the early research was done in the 1970s and the 1980s with NAS, is when they saw these moms who were on, on heroin or cocaine, and they noticed that these babies all presented with the same kind of signs and symptoms, that they were not newborns, that looked normal. So they started to research it, and then they really came out in the mid-1970s based on their observations, both Dr. Finnegan and Dr. Lipsitz, on how to score them and then how to treat them because of their withdrawal symptoms. So the Finnegan modified tool is the one throughout the United States that probably most nurseries and NICUs use. It has always been too cumbersome, though. It is a 21-item tool that you would have to score a baby on. You're going to lose your objectivity when you have to score a baby with so many different items on a tool. There will also be variability then between each observer, so we don't necessarily have a consistent score because I might score the baby one way, Bridget might score the baby another way. So again, you lose that inter-observer reliability when you have such a cumbersome tool to use. Her short form, though, is the latest one that has come out and which we've started to use in the nursery, and it is less cumbersome. There are only 7 items, and you can score the baby anywhere between a 0, and that would be a sleeping baby during their time that they would be scored, up to 16. There's an increased ease of use with this tool. It is improved. Research has shown that there's improved reliability and accuracy among these scores. This also allows parents to use the tool at home. So if you're discharging a baby on day 5 or 6 and you're still a little concerned, you can actually teach the parents how to use this tool. It's very simple. In the NICU, when we have our babies, we engage our parents in actually helping to score the babies. They know why we score them, when we score them. We do it together so that they see, and that's how we educate them. And even you can use it in your outpatient pediatric centers. So if you have a mommy who goes home and on day 6 and on day 8 she's calling and she's saying, this, that, and I'm concerned about this, I'm concerned about that, you can actually bring the baby in and you can use this tool as a guide even in an outpatient setting because it is much simpler to use. Since, I want to say probably late May, June, and July, all of our nurses were educated on how to use the short form and really how they should be scoring a baby for NAS. And the babies that we are now getting from the newborn nursery are right spot on with the numbers that we're getting in the NICU. So we get a baby from the nursery, they're scoring a 12. Our NICU staff then scores them, they're getting a 12. We had a lot of variability when we used the modified form. We'd have babies that were scoring too high in the nursery, and then we'd get them and they'd be scoring much lower for us. But really now, with the education and the use of this tool, we're really finding there is consistency. So when we get a call, maybe like from Dr. Grusco, and he's like, Val, I have this baby, the kid is scoring a 12, we're all kind of on the same page with our scoring, which was not something we saw in the past. So that's really a very good thing because it proves, one, that the tool is reliable and that there's accuracy between the different nursing staffs in actually scoring these kinds of babies. So we are very much embracing the short form. You still have the choice in the nursery to use the long form if you prefer, but they are definitely capturing the babies that need the NICU admission. These I'm going to just go over. This is actually what I taught the nurses on how they actually score them. There is a program called NeoAdvances that actually goes through and teaches each scoring and how we score the babies. Because again, there's always some subjectivity to how we score, but the definitions have definitely helped with the consistency in scoring. So we won't hit any of these, but just so you know, the nurses had gone through an extensive training on how to score, when to score, and why to score. care. And it was interesting when looking at their comments that, oh, you know, I would have scored differently. So a little bit of education has actually also helped with the reliability of our tools. So we'll just skip over some of these. So what do you do in the Well Baby Nursery with these babies? You try, the ultimate goal is to keep the mother and the baby together. So their rooming in is very important. It is always a good idea not to have these babies in the general population in the nursery. We all know that if we have 15, 20 kids in the nursery, it's a very high stimulating area. These babies don't tolerate high stimulation. So there are definitely some non-pharmacologic management measures that we can use as both nursing and medical providers in caring for these babies, but also to educate the moms and dads and the other caregivers that may be involved in caring for this baby upon discharge. So there's definitely some soothing measures that we look at. Natural light is fine. Quiet settings, no loud noises or voices, no high blaring televisions. They actually like music. Some studies that are going on right now in Australia are really looking at aromatherapy and music therapy in these babies. Aromatherapy and music therapy has been used in other research for preterm and full-term babies. So as much as there's no research for NAS at this point, they do feel that there is enough validity in some of the studies that we can incorporate it into the care. And we definitely find that it works in the NICU. If we can, we put them in our isolation room, which is our quieter room. Parents can actually stay in that room with them. And they definitely do not like the loud, busy beeps that are found in the NICU. So if we do have to put them in our main NICU rooms, we tend to find a quiet corner for them. They really do like rocking, but it's not rocking like this, like we would rock a normal term baby. It's vertical rocking. So you actually take the baby and you put the baby in a C hold where your hand here supports their head, your hand here supports their bottom, and you just gently bend them and you rock them up and down. That works very well for the disorganized babies that you cannot soothe with just a pacifier, rhythmic tapping. So there are definitely things that we can do as providers in teaching our families how to care for them. They do like swaddling. Even when we examine these babies, we should try not to completely undress them. That totally disorganizes them and they cannot get back to their settled state. So during your exam, some nice pressure on their head. Only undress the part of the area you're looking at, and that's what we teach our parents. When we wash them, we just expose little parts of their body. When we examine them in the NICU, we just expose little parts of their body. So we'll start unswaddling them here, and then we will swaddle them back, and then we will move down to their lower body. But we do not undress them, and we do not keep them exposed for too long because then it doesn't really give us a real guidance on what their next NAS score, because was it environmental? Was it some stimuli that we caused for the baby that has caused more disorganization versus their actual withdrawal from whatever substance they were exposed to? So we spoke about already trying to keep them together, and it is definitely a little bit of a sticky situation. Even if CPS is involved, whether it's for removal or whether it's preventative, they should be together as much as they can. Or if you've already identified CPS has identified a caregiver and it's somebody within the family, we still do try and incorporate them and really engage them in the care of the newborn. It's very hard when they are going to be discharged and they're going to go to foster care. That, unfortunately, with the way our system works, we have no real plan once they get discharged. Even for us sometimes when our NAS babies are medically cleared and they're off their medications, sometimes the CPS worker just comes and picks them up and then they're taking them either to the children's home or they actually have identified a foster family. So sometimes we don't even have that interaction because this is not a normal newborn going home. There really needs to be education, and that's hopefully one of the quality improvement initiatives we'll work with next year in 2016 to really get some of our community resources together to care for these babies. As I spoke about earlier, containment is very good. To keep them swaddled, do not totally expose them. And we use skin barriers to prevent the excoriation on their bums, especially with the loose stool. So we use Ilex. We find that either the Bonex or the Desitin is not a strong enough barrier for them, so we will put Ilex on these babies soon as we get them, and so that they don't get that breakdown as well. We do use small frequent feeds with them. We do feed them on demand. We do not put them on a schedule, and we do encourage breastfeeding when the mother is in a program and her urine drug screens have been negative. One of the things we need to just be cognizant of, we have a routine in-house drug screen, which does not test for methadone, but it will test for everything else. And then we have a comprehensive drug screen, and that will show up on methadone. So you may have a mom on methadone and she just had an in-hospital screen and it was negative. So at that point in time, you know she wasn't doing anything else, but it will not pick up her methadone use at that point. The formulas we use are either Similac sensitive or Gentilese. We really find that the babies digest them better. They don't have as many spit-ups. They don't have as many loose stools. You don't hear their little stomachs rumbling all the time as what we found on regular formula. And we can, through dietary, increase that caloric intake with that if they need it. So if a baby needs a 24-calorie sensitive or a 26-calorie, we can have dietary make it up for us. Mom's milk has definitely been shown to decrease the severity of the abstinence, decrease the length of stay, and decrease the duration of therapy. With methadone, there is a small amount that is transferred over. It has never been able to be quantified because every mother's metabolism rate is different, but there is evidence that shows these things do help when we're trying to feed them. So in interacting with these addicted mothers, it's important that we take the time to self-reflect on our own moral perceptions of addiction. There is quite a bit of research out there, not so much for medical providers, but for nursing staff. When these moms are interviewed during research, that they definitely feel that they're being judged, that they are morally depleted, that nobody thinks they're worth anything, that they're a bad mother because they have an addiction, and they have this chronic condition, and they really will not trust you. But the research on the flip side that shows if we are positive with these moms and these caregivers, and we actually encourage them to partake in the care of their newborn and really sit with them and talk to them, they take this home with them. That's a positive reinforcement that we can provide, and these moms do better with these babies at home. Their coping is better. They tend to stay cleaner. They do not get as frustrated when their babies themselves are having one of their episodes. So it is really important that when we talk with them that we use kindness and sensitivity. We should be non-judgmental, and we should be non-confrontational with them, and we should not punish them because of their addiction. So our care should really be based on cooperation and acceptance and positive reinforcement and being honest with them. They may see me one day and, you know, I will talk to them, and they might not at that very first encounter divulge their secrets and, you know, their addiction and why this is happening and why that is happening, but hopefully on our second interaction they would, and that's really what's important. And our moms definitely stay some time with us, and we might not always in our first 24 to 48 hours kind of get the whole picture on what has gone on in their life and their trauma and the reason for their addiction, but they learn to trust us. And when they see that we are not judging them and that we are really there to help both of them, whether CPS is involved or not, we do find that they are very forthcoming and they are honest with us. And so it's a difficult position, I think, for all of us to be in, but mostly for them. And if CPS is not removing this baby, then we really should be helping them. One of our goals should be to absolutely help them to get ready to take this baby home. These newborns can sometimes have these abnormal behaviors up to 9 months of life. It's not that day 7 these behaviors go away. They can sometimes have them for quite a while. And then their children, when they get to school age, some of them will have behavioral problems, some of them will have attention deficit. Most of the research that came out in the late 1990s really looked at the cocaine babies, and while they may have had EEG changes back then, when they got to school age, they're really not finding that they were that different than any other child, and some of the research is actually showing that it's not so much what their in utero exposure is, but more what they go home to. What kind of environment do they grow up in? Is it a stable home? Is it a loving home? Is it a home that the parents are interactive and, you know, are going to see the pediatrician, and if milestones are not being achieved when they should be, are they following up, you know, with the pediatrician's suggestion for a developmental evaluation? I can tell you that in the NICU, Dr. Jordan Case out of Westchester sees all of our NAS babies, and our NAS babies are doing worse on their Bailey exams than our preterm babies are doing right now. So he's got a number going on where he's looking at the NAS babies, and hopefully in the next 2 years he'll be able to share that information with us for our region and look at them. But we were quite surprised when he came last September and spoke to us that our NAS babies developmentally are doing worse than our preterm babies, and even some of our sicker preterm babies, when he's seeing them out at the 2-year mark and 3-year mark, their Bailey scores are not where they thought they should be. Is part of that environmental? Quite possibly, but it's important that there is a discharge plan in place for these babies. Other things that we can do, as we spoke about, is really have them participate in the care. Don't take them out of their room to score them. Score them. The nurses are being taught to score them with the parents and look. And parents are keeping a sleep record. So how long did your baby sleep? That's also very important when you're looking at actually how to score the newborn. And then definitely before they go home, there needs to be a social service staff evaluation and CPS if they are indicated. So what do we know? We know that addiction has reached epidemic proportions because of the maternal addiction, and now we are seeing all of these babies with the sequelae of neonatal abstinence. We know that it will affect many body systems of the newborn. Withdrawal can be seen as early as 24 hours in some babies, but can also be seen as late as day of life number 7. And then we need to identify the appropriate scoring and interventions in the nursery. So what can we do now? We need to standardize and have supportive care for the mother and the newborn in the nursery. You can consult with us in neonatology when you feel that there may be something going on, their scores are escalating, or you have a question. And in discharge planning from the nursery, we need to make sure that we identify who their pediatrician is going to be, and that these babies are not lost, that if there's a appointment made in 48 hours that they're coming, and if they're not coming, we've had this problem in the NICU, the numbers they gave us, they're disconnected, they're not there, visiting nurse goes out. So it's very important that in the community, even though it's more detective work for us sometimes, that we really don't lose these babies to care. It is very important. We need to make sure that before we discharge them, they are medically stable, so anywhere between day of life number 4 to day of life number 7, depending on what the maternal exposure was. And this is really the recommendation that's in the clinical report from the AAP from Dr. Hudak and Tan. We definitely need to make sure that social service and CPS, we have clearance. There are some CPS cases that are preventative, so they are not taking the babies away from their mommies, but it's more for community support. So again, those points are important for us to know, and that their follow-up appointments are made and kept. It is also part of education on our part that they understand the signs of what escalating withdrawal would be and how to care for the newborn and when they should reach out to you if it's before or after a scheduled appointment. I do want to just talk about a couple of things. There are a lot of moms now that we're seeing with a poly use. I won't say it's always abuse. A lot of them, because of their addiction and their low self-esteem and anxiety and stuff, are on SSRIs. So those babies are very similar to the nicotine-exposed babies and the marijuana-exposed babies. While they will have symptoms that look like NAS, which really is a diagnosis of an opioid dependence, these babies will have tremors, they have irritability, they may not eat well, but definitely by day of life 7, they are kind of really waning away from those symptoms. So the difference with those drugs categories are, as it leaves their body, the babies get better. With your opioid dependence, happens, as it leaves their body, that's when you see them start to withdraw. So that's really the difference. So you can see babies where moms are on Buspar and other SSRIs that they're using, that they will have those tendencies of an NAS baby, but they go away and they don't return. With the opioid-dependent babies, they stay and they actually escalate because those are the babies that are going to go through withdrawal. And polyuse during pregnancy makes it very hard to manage some of these babies as well. So that's pretty much what I had to talk to you guys about. The first part of it was educating the nursing staff, and I think they've done a wonderful job with really working with the short forms and really their own comfort level. We never had addiction before in the nurseries. We most certainly didn't have these babies in the NICU before, unless you're an oldie like me and you've been in a children's hospital since the early 1990s where we had that surge of cocaine, and then we did have all of those babies. It's very different now. There are designer drugs out there. There are people taking street drugs. There are little factories making their own drugs out of bath salts and everything else. So it is more complex for us as medical providers in caring for our newborns because we're not always sure of what in utero exposures these babies are presenting with. And hopefully in the next 5 years, with the federal government really taking a good look at, we should have some more standardized care plans in caring for them. So, questions, comments, concerns that I can help you with? Dr. Fenner?
Yeah, so I'm sorry to come in late.
That's okay.
One of the issues that has been coming up is when to discharge these babies.
Correct.
I like your slide saying 4 to 7 days, and I've been pushing to keep most of these babies. It does get into a bit of a trouble with exactly some of the other stuff that you're saying, and that is that we're trying to, so now you're discharging a mom without her baby.
Correct.
And exactly the kind of situation where we're trying to make sure that we get a good parenting thing and a good parenting bond going on from the very beginning. It becomes difficult that way.
It does become difficult, and unfortunately, even the setup in the NICU and in the Well Newborn Nursery, we don't have what we call these border rooms, where mommies don't need to stay. They're medically discharged by their OB staff, but there is definitely a medical reason to keep the baby. So what do we do with them? Yes, it is very difficult, and unfortunately, our setup being here that we are a maternal child division in an adult medical center, that's even one of the challenges we have. And that would be one of the things I'd like to look at in 2016 is really how and where are we going to care for them. A lot of times if we have the babies and their scores are just borderline and we're getting them because they're 9s and 10s and we think they're going to escalate, we do try and put them together. There are times where we can't do the same thing, so you're right, what do we do with them? And that's one of the issues I think we have just environmentally with our setup, because we can't have every mom boarding when labor and delivery is full and all of your beds are full on your postpartum unit. So are your scores borderline? Do you have a mom who you know is reliable and or CPS is involved or not involved? Do you send those babies home and do you see them every day? That is an option you have. The other flip side of that is then if their scores are escalating on day 5 or day 6, do they need to be admitted then to pediatrics, or do you think you'll be able to ride it out? How long are they sleeping? Again, one static score of a 12 does not necessarily commit that baby to, having to be admitted and or getting a pharmacological agent added to their therapy, because sometimes our scores are just static, so we have to look at the big picture. So I think if you have a good rapport with the family you're sending home, you might then be able to send them home on day 4 or day 5, but just follow them then every day with that understanding that if the scores escalate, they may need to be readmitted. And I don't think, Dr. Wu could probably, I don't think there's a great number of babies that are being readmitted from the pediatric offices because of their scores escalating. So I think it's more the management. And honestly, the babies are going to do better when they're with their mommies, skin to skin, kangaroo care. And if you know that environment is safe, you absolutely, as long as you're going to follow them up, it doesn't have to be an inpatient necessarily follow-up when you're reaching that day 4 to 5. You certainly could try.
Our difficulty there is that, again, a lot of these people we don't have any particular rapport with. When you're talking about the realities of which day of the week will they be going home.
Right.
If we're going to be following them up day by day, it won't even necessarily be the same individual provider who's going to be doing doing that. And so it sounds good, and probably in a limited number of situations you're going to be able to set that up. But I think the majority of situations, I think what we need to be doing, and I'd just like to hear the consensus from the people here in terms of this. I know I've been pushing to keep these kids for, around 5 days or so. What's been the experience of the other people who make rounds and see these kids in terms of discharge and so forth? Any particular comments? I don't see very many people here who actually make rounds. Has that been a problem for people keeping the kids? Has everybody else been keeping the kids until about that point? Again, I think it's hard for us, I got to say, it's hard for us to think about sending a kid home who's actively in the process of being watched for continued escalation.
I think the problem is sometimes, without the insurance, 48 hours vaginal delivery, 2 hours, C-section. And I think sometimes the nurses sort of tell the parents they're leaving in 48 hours, and then they're really mad at you
when you're the medical provider going in and saying not. Well, that's a component.
Straight up
right.
At the very beginning.
But I feel like maybe the nurses shouldn't say you're going home.
Right, and that's something then if you speak with the leadership for maternal child, that might just be a little bit of re-education that they need. Dr. Gretzko?
Valarie, it's important, like they kind of mentioned, not many people making rounds from other groups are here, or even in our group, Essentially, if we can get straight, from the hip communication from Dr. Kovacs and you, mentioning that if you had a baby whose mom is on methadone or there was a positive drug screen, the baby's going to stay a minimum of 4 days. Again, we are always thinking that, by 48 hours, everything looks great and rosy, things are going to be all right.
Right, but that's for your healthy newborn, right? Right.
That's one thing.
Doing something like methadone where you really could have a very late.
You can. You absolutely can.
Protocols, and it should be a direct communication with all the pediatricians, patients, see babies, including family practitioners.
Right.
Second, the communication to the families as soon as the baby is born. That's what we're going to be doing, so we're not the bad guys, coming in. And third, and most important, like you mentioned, I do have a baby for 4 days, seemed to be fine, was scoring very low, was sent home, to grandma. She knew something was wrong, but she still waited 3 days to come to the scheduled appointment instead of bringing.
Instead of calling, right.
The baby was admitted in pediatrics, but essentially she realized, that the baby was crying all the time, shivering, and the whole thing, all the autonomic things, the pouring, and still, she waited 3 days, even with the education, so we really need to work.
Yeah, and that is one of the things, too. I mean, visiting nurse can also help with that. I mean, we offer.
Normally, it never happens, a day after they go.
Right.
They go
right.
True story, as a pediatrician, you know that, you're telling, okay, come back in 2 days or come back in 2 days because it's a Friday and they're coming on a Monday, and you tell them if something goes wrong, but again, you can't track it.
Right, we can't track everybody. There will definitely be babies that we will lose, like any patient. We will lose them in the community. We won't always capture everybody. But I think just the fact that we are cognizant to these babies and really do our best, I think it's important for them. I mean, we as a neonatology division are actually looking at setting up a clinical practice guideline. That is our goal for January. I presented a couple of guidelines that are used in other centers with really very good success, and because we all have different parameters to treat. Even though the Finnegan school says 2 consistent scores greater than 8 or 12, we within our practice do different things. If we have mommies and daddies that are very interactive and are very engaged in their care and they really don't want us to start meds, are we really doing that baby justice by letting that baby score a 17 and not treating that baby? So there's a lot of things that we are actually looking at. So maybe once we set our stuff all together, we can bring it to you.
Piggyback onto that.
Beautiful.
Our practice guideline, it does not necessarily have to be an absolute guideline.
And a guideline is just that. It is a guideline. It is not something that's set in stone.
This is epidemic. 3 years ago, 4 years ago, we're seeing 1 or twice in a year a patient with, with a withdrawal. Right now, every other week I'm making rounds.
Well, I can tell you that we meet with Dr. Heller on every Tuesday, the maternal child division, and she averages anywhere between 5 to 10 moms who are addicted delivering every month. 2 weeks ago, our NICU census was 50% NAS babies, not preterm or critically ill newborns. 50% of our babies were NAS babies that required pharmacological management. So it is something that we're going to see more and more of, and it's definitely something as a medical center and a maternal child division that for 2016 we're going to have to look at some quality improvement measures on how we can care for them, because these babies are not going away, and I think we're going to see more and more of them.
Let's invite you back to our departmental meeting, not the 8:30, but the 9:30 meeting when you have the practice guidelines.
Sure, that would be great. We can plan for that for the first part of next year.
Okay.
Okay? I don't want to keep you any longer because I know your business part is going to.
I just wanted to know anything about moms who are Adderall or high doses.
They sometimes, those babies will present with some withdrawal, and they will be the same kind of way, and that's some of the research that's coming out now. These moms that are on these high-dose attention deficit medications, there's not a lot of research for them yet because, again, this is now another system of maternal exposure and therapies that they're being used, but these babies are very excitable, and they almost act like the SSRI babies. So what we're finding is that they can actually have those same kind of symptoms. We actually had a mom who had very high doses of caffeine, and we had no real reason. Everything was negative. We're like, what is going on? This baby actually developed apnea and withdrew from the caffeine because this mom drank like 5 2-liter bottles of regular Coke a day plus on top of coffee. And for days, we're like trying to figure out why is this full-term baby having apnea? And then it came out. And who would think that it would be caffeine? But those are, right, but those are some of the things we're finding. So we can't forget that it's not only the drugs, the illegal and the prescription drugs. There are other things that moms are taking out there that can, you know, cross the placenta, and we need to be worried about. We would have never thought caffeine would have done that, but that when she told us how much caffeine she was drinking, it made a lot of sense because on day 3, this full-term baby is having spells, and we're like, why? So.
My concern, I had a mom. I think she was on or something of Adderall, and baby almost like that. And nursery, I mean, at that time, it wasn't too bad, but then I saw in 48 hours, you know, almost dying. And I thought it's mom on drugs and
right.
And the minute I opened my mouth about it,
yeah.
she told me what it was, you know. So do you think that those who are on this kind of medication, just in case, should be doing that thing on them while they are?
I think it's important that all mothers are screened appropriately, and that's some of the drops that we have in the care regionally at this point. I think it's so important when the moms are screened on their prenatal visits. Like some practices will screen every mother no matter what on their first. But I think it's important that the history is taken. You know, so what kind of medications do you take medically? They may not tell you on the first visits, but they have 9 months with these moms, and I think that's where we need to capture them and really work with them, because I think what happens is it puts us in a difficult position because you as the pediatricians get them for maybe 4 or 5 days. That relationship isn't developed yet. The relationship is developed during their prenatal care. So I think we have to regionally have better screening for these families and these moms and really start with there. And again, there will be some that will become very defensive because that's part of their addictive personality. And I think sometimes we just have to say, this isn't punitive. We're really here to take the best care of you and your baby. So that's why we ask these questions. It's a general screening question that we ask all parents on their first newborn, however you want to word it, so that it takes the onus off of them. And that's probably one of the only things you could do at this point. But yes, the research is not really out there on these moms that are on these high doses of Adderall, but it is definitely something that's being looked at right now.
Because more and more adults ADHD.
Right. Right, and it's being treated and it's being recognized, and that's something then that's going to happen. One more, Dr. Gresco, and then I'll let you guys.
Comment. You know, I do believe that the regular, nursery nurses are doing a fantastic job.
They really are.
They can score much better than what we do. They say, that's a number, no doubt. Okay.
Right.
So you really are.
And that is definitely something that we've seen since we've provided their education, and the fact that they're more comfortable using the short form. And like I said, there's not that variability that we saw before we started using it. If the nurse says, Val, the baby's at 12, and then we have another observer score in that NICU, we're getting the same numbers. So we know that there's validity and reliability with that short form. Change is different, and sometimes we all have, you know, a little bit of resistance to change, especially when we've been doing this for a very long time, like we all have. But I think it's important that, especially in nursing, we use our evidence-based practice that's out there, because it supports the nurses and it gives them areas that they can actually take their knowledge from and build on their wisdom. So, all right, I want to thank you all very much. Enjoy the rest of your meeting. Happy holiday, everybody. I'm sure I'll either see or talk to you at some point in time.
You want to just keep on